So we are really honored and delighted today to have Dr. Velma Scantlebury giving us a talk about kidney transplantation, which is really a subject which is close to my heart. But before I introduce our speaker, let me go over some housekeeping issues. So as always, for CME credit, you must sign in and must include your email and credentials. Do not miss our March 1st Tech Talk with Momita Bhattacharya from University of Delaware, and she's also going to talk about kidney-related issues. Also, please note our February 16th Innovative Discovery Series. We will have a special guest, Dr. Matthew Hoffman from Christiana Care, speaking on improving perinatal outcomes through research. So please also register to help us prepare. And as always, the full schedule is posted on our website, DE-CTR.org. And finally, I'd like to remind everyone that the registration is still open for the Axel Community Resource Exchange, which is a big conference happening on March 12, 2018 at University of Delaware. The keynote speaker for this event is Dr. Georgia Dunstan, who is the founding director of the National Human Genome Center based out of Howard University. She's an accomplished speaker on health disparities and genomic research. So back to our speaker today. Dr. Scantlebury is a transplantation surgeon and currently the Associate Director of the Christiana Care Kidney Transplant Program, as well as the Director of the Outpatient Clinics. She has an MD from Columbia University, and she went through a transplantation fellowship from University of Pittsburgh in Pennsylvania. Prior to come to Delaware, she was Professor of Surgery and Director of the Kidney Transplant Program at the University of South Alabama Health System in Mobile, and she was also the Assistant Dean for Community Education. Dr. Scantlebury has a very impressive number of awards, from her first award, which was a Woman of Spirit Award from the Carlow College of Pittsburgh in 1996, to I Am the Dream, celebrating diversity and achievement in medicine, which was an award from PICOM in 2015, and finally, to the Most Powerful and Influential Woman Award, presented by the Pennsylvania Diversity Council in 2016. Congratulations. She has a very long list of peer-reviewed publications, books, and book chapters, and has given multiple talks and presentations. So we are very excited to have Dr. Scantlebury with us today.
Thank you all for coming to today's lecture. And I know most of you are driven here by the wonderful food, but along with the food, you're going to have to listen to me at least for a while anyway. So I am going to touch on the topic of ongoing issues in kidney transplantation, and also in terms of, can't really cover all of them, but what I thought was important. But I will start with a little background as far as history. I do have to make sure that I have the no relevant financial disclosure statement on there, so make sure everyone's aware of that. And some background in terms of kidney transplantation. You know, the first successful kidney transplant was performed in 1954 in this country by Joseph Murray at Peterborough Hospital, and it was done using identical twins, Richard and Ronald. And the reason for this was that the organ, because they were identical, there was no issue with rejection and no evidence of recognizing that tissue as foreign. So let's go back in terms of various pioneers in organ transplantation. Alex Corral received the Nobel Prize in 1912 for his ability to come up with vascular suturing and triangulation in terms of putting blood vessels together. However, Matthew Jabelet of France was actually the first one who introduced the suturing of blood vessels for thickness, but he didn't get the award. Alex Corral did, and we also know of Emmerich Ullman, who performed the first successful kidney transplant in 1902, and he used a dog using autotransplantation, and he also went across species, dog to goat, xenotransplantation in those days. But none of them survived for any great length. More than 100 kidney transplants were performed by Ugner, and the third and fourth human transplants using monkey donors in 1909. the first human kidney transplant was performed by the Soviet surgeon, and he had done a total of 5 human transplants. And this was followed, and the way this was done was because they knew that these kidneys would not last very long, so most of the kidneys were placed in the thigh to be able to watch the kidney to see if it would hyperacute reject or whether it would last. And so most of them did not, even, and so these experiments went on and on. Richard Lawler, a urologist in Chicago, did the first human transplant in 1950. Unfortunately, this patient had impaired renal function, not end-stage kidney disease. The kidney made urine, lasted several months before it was removed, and the patient then survived with her own kidneys. And so there was some criticism of whether or not this patient actually needed a kidney transplant, or whether her acute phase of renal failure somehow resolved and her own kidneys kicked in. So the ongoing challenge in the early days was really about how do you prevent rejection? Yes, we had mastered the ability of techniques in terms of putting blood vessels together and be able to try to achieve some evidence of survival, but the bottom line was that there was no available method to prevent rejection, of preventing the host from recognizing this graft as foreign tissue. And at that time, there was no dialysis treatments available. So the previous work in terms of understanding rejection had to do with doing skin grafts in terms of deciding whether twins, acceptance of fraternal twins, skin graft from one to another, in terms of deciding whether they were identical or fraternal twins. And so before the first successful transplant was accomplished, Joseph Murray actually used a 2 donor recipient pair to try skin grafting from the donor to the recipient to make sure that the recipient was going to be able to accept his brother's kidney, which was thought to be identical, but not sure 100%. And so the evidence of skin grafts being able to be accepted led the way to the identical twin transplant. So we move on, and now we're doing transplants. We have some success, but no long-term. And so what could be used to prevent rejection? The first thing in 1958 was total body irradiation, a condition where the recipient is radiated and prior to transplant, and this is followed by bone marrow. Somehow most of these died, mostly because of infection, and one survived, and that patient received a fraternal twins kidney and lasted for 20 years. But total body irradiation just led to many devastating consequences. So steroids were used as an adjunct initially to total body radiation, but still there was very little survival. Roy Kahn introduced 6-mercaptopurine, which is a breakdown of azathioprine, and this was also used for cancer treatments and showed that there was survival within adult kidney transplants. They then decided to put together total body irradiation with 6-mercaptopurine and still has some failure in these patients. Thomas Starzl at that point appeared at a meeting and presented a paper using a combination of steroids, prednisone, and azathioprine, and he was new on the scene to transplant, but he was able to show that with this combination, he had led to survival of long-term kidney transplants, and lo and behold, this sort of took off. And within the year after this discovery of prednisone plus azathioprine, there was 50 new transplant centers were opened within the United States in an effort to start this new phase of transplantation with the ability to have immunosuppression. So over the next 25 years, there were many different development of different immunosuppressive agents. Dialysis was available in 1943, but it was based on criteria of who was suitable to receive for prolongation of life. And so it was really an ethical debate as to who got to be dialyzed and who didn't. With the funding of the end-stage renal disease program by Medicare in 1972, we then had coverage for patients with end-stage renal disease, but through that availability, there was a discovery of antibody screening from the discovery of antibodies in the recipient from the donor that led to hyperacute rejection. And so these were things we were able to overcome. Tissue typing became, we were able to type patients in terms of see how they were related or unrelated in terms of donors. The acceptance of brain death in 1968 allowed for deceased donors to come aboard with the ability to then increase donor availability. And so we then have preservation, allowing organs to be transported across the state and various across the country in 1967. So when we look at current statistics, we see that we are now nearly 115,000 persons are listed for transplantation. Sometimes you see a number that's higher than that, but it has to do with those who are registered in different areas, as patients can multiple lists. So when you see a higher number, it may mean that there are quite a few thousand people who are registered in different locations. So they're maybe counted twice or three times. And over 95% of these patients awaiting transplantation are awaiting kidney transplantation. It's the greatest need in terms of organ transplantation. So when you look at transplant operations being performed, we see that over the years, there's a vast increase in the number of patients added to the waiting list. But in terms of the actual transplants, the numbers have pretty much stayed between 18 to 22 to 30,000 transplants as we move into the more recent years. So we don't make a dramatic dent in really addressing the need for kidney transplantation. So what we have is, in terms of ongoing issues, is that we have more patients added to the waiting list. There's not enough organs to go around for everyone. Kidneys don't last forever. They're still subject to rejection and chronicity down the line. And there's not enough people donating in terms of working on the need to have more donors, both living and deceased donors. And there are financial barriers. Not everyone can afford to have a kidney transplant. Within our own area, we have the Gift of Life, which is our local organ procurement organization. In 2007, they had the highest number of life-saving organs per year with 565, resulted in over 1,500 transplants within this area. The Gift of Life works with the 15 transplant centers in our area, Eastern Pennsylvania from Harrisburg over, Southern New Jersey and Delaware. And nationally, we see the numbers, and locally within our area is 5,300 men, women, and children in our area awaiting transplantation. As far as donation work, the donation rates, Delaware has the highest percentage of our organ donation rates in terms of people signing up for organ donors, Southern New Jersey at 40, and Pennsylvania is still under 50% in terms of people willing to be organ donors. So that is a driving issue that still needs to be addressed.
And this includes deceased and living organ donors?
This is more in terms of signing organ donor cards through the motor vehicle bureau where it can be registered. So candidates, we look at those waiting kidney transplantation, 95,000. In terms of donors, there are those there's over 1,600 patients who are on the kidney pancreas list. They do take a few of the kidneys away, but still under 2,000 patients. And the number of donors in 2017, in terms of over 16,000 donors, deceased donors slightly over 10,000, with living donors being slightly over 6,000. Remembering that most donors not all deceased donors will give you 2 kidneys, which is why the numbers don't add up. One kidney may not be allocated for some reason, so there's maybe some difference there. So there's the increase in need, a growing number of patients with end-stage renal disease, as we have the 2 leading causes being hypertension and diabetes. And so these patients get listed for transplantation. Patients need to meet medical criteria, and the issue we have is that kidneys don't last forever. Younger patients, if you're a pediatric patient getting a transplant under the age of 10 or under the age of 20, if you have a living donor, that may last you about 20 years, may plus or minus 5. At some point, you'll need a second transplant, and at some point, you'll need a third transplant to get to a ripe old age. Patients with prior transplants, such as heart transplant or liver transplants, because of the medications, will sometimes a certain percentage of those patients down the line will require a kidney transplant. So you have all these added to the list in terms of those in need of transplantation. As I talked about, there are more patients diagnosed with high blood pressure and diabetes is the #1 cause of chronic kidney disease and end-stage kidney disease, with patients listed for transplantation. There are many patients who are diagnosed late because diabetes and high blood pressure are, and most kidney diseases are silent diseases. There's not a whole lot of symptoms, and so patients are diagnosed usually, unless someone is following them very closely. We see a fair percentage of patients who are diagnosed acutely with chronic kidney disease, needing dialysis within months to a year. Some of it has to do with their socioeconomic status or the financial barriers or inappropriate health care. So the solution to this is beyond my scope and also beyond this lecture in terms of the collaborative efforts that we need to really hit our communities and provide appropriate medical care. So we see our wait list, those that are deceased donors transplanted, and those that are deceased donors recovered. When we look at the ethnicity of transplant enlisted patients, we see that in terms of Caucasians, those patients who get transplanted, they make up just over 50% of the transplanted patients, yet they're not 50% of those waiting for a transplant. We have for African American, 34% of those are on the wait list. Less than 25% will get transplanted. Same for Hispanic and others in terms of so for people of ethnic and people of color, the rate of transplantation is not the same. And so those are issues we face. And so while within our area, the Gift of Life was able to say that there are 20% increase in kidney transplantations over the last 5 years, we're still faced with the issue of the majority of organs coming from deceased donors, and the need to figure out how can we get more patients transplanted either by increasing the deceased donor rate or increasing the living donor rate. So when we look at living donation, we think about altruistic donors versus those that are related or unrelated. Altruistic is someone who out of the kindness of their heart wants to give a kidney. And don't everyone raise their hand, but how many of you in the room would think about giving a kidney to someone you didn't know, or just because you have lived a great life and want to help someone else? So there are few and far between, but we do get some patients who want to do it. And we were fortunate enough to have 2 patients come to us last year who resulted in altruistic donation. They just wanted to give a kidney to someone just to help without knowing that person. So in terms of why living donation, the survival is better. There's better lifespan compared to a deceased donor. Living donors, this is living donor, deceased donors with no match or 0 less than 5 antigen matching to a perfect match donor, deceased donor to a living donor. In terms of the expected year survival is still great, even if there's no matching, which is the advantage even in terms of spousal donation, our best friend. There's still that advantage, despite the fact that, and certainly, but if you have a living donor that's an identical match, you're going to get the greatest survival long term. So the advantage and disadvantage of living donation, certainly the one thing is we tell patients is that this person who wants to give to you, this is your kidney. You can have preemptive transplant option. You can decide when you want to have that surgery done at your convenience or even at the convenience of the donor. There are better outcomes in terms of the immediate function of the kidney. There's very little delayed graft function. And you can usually tailor in terms of the haplotype match. If you have someone coming forth who needs an organ and you have 5 siblings who are all eager and enthusiastic to donate, we can pick the one that's most suitable based on perfect match if they're all willing and healthy, provided they don't have any underlying diseases that may limit their donation. Disadvantages, yes, there are some very minor and major complications. Certainly any operation is subjected to anesthesia and post-op complications. Certainly the long-term risk in terms of kidney transplantation is very minimal. There's very little mortality. It's a long process in terms of making sure this person isn't really coerced to being a living donor and that they truly want to be a living donor. There's no underhand exchange of funds or property for donation. And the person, some donors may have the disadvantage of feeling some let down depression post-donation because the emphasis goes to the recipient who is now being focused, and now the donor feels like they've done a good deed, but not really no longer the center of attention. So, however, when we look at living donation within ethnic groups, we find that there's one article written by from Johns Hopkins Hospital that look at ethnic and racial disparities in terms of patients receiving kidneys from live donors. And while we see that in looking at the incidence over years from 1995 to 2014 in terms of having those with at least a 2-year graft survival, we find that there has been a tremendous increase in the Caucasian increase in living donation, while within the Black and Hispanic, much less so, but certainly there is a slight increase for Asians, but within the Black and Hispanic population, there's a decrease in living donation. And so this becomes a point in terms of looking at the number of persons on the wait list and those that really need organs, and how can we really make a dent in bringing people of color to the table in terms of thinking about addressing the need for living donation. And when we look at the need for live donors transplants within the US, and we look at all those patients with end-stage renal disease and the increase in numbers over age, we find that certainly age and race and ethnicity are the two groups of people who continue to rise in increasing number of the end-stage renal disease and dialysis rates. So we have an older population, which we see even amongst our own patients here that come for kidney transplant evaluation, and certainly the increase in rates of African Americans being added to the dialysis and the increase in rates of end-stage renal disease within African Americans, primarily due to high blood pressure. And so the goal is to be able to think about living donation for the older patients and minorities so that they can get transplanted earlier. So when we look at living donor transplant and look at issues ways that we can increase this, I have a folder over there. Amy Waterman had worked with Johns Hopkins Hospital in terms of looking at a consensus report of what can we do to really introduce living donation in terms of education and to patients on dialysis. And the thought was that, one, those patients in need of transplant really educate the community, look at having conversations with their primary care and community nephrologists about preemptively getting a living donor transplant. You know that you're in stage 3 or 4 and dialysis is impending. Why not think about avoiding dialysis and looking for a living donor so that you can get a transplant, and those patients who do it preemptively have better outcomes. This systematic education allows for those to get this information either at the dialysis center or the doctor's office. So by the time they present to the transplant center, they're well educated about the benefits of living donation and can proceed quicker through the process. The dialysis center is a great group of people in terms of nurses and the staff in the dialysis center is about educating them because those are the ones who are in primary contact with these patients on dialysis. And also looking at public education and more awareness in terms of discussing the need for greater living donation. This is one of the patient education options, Explore Living Donation. I have a pamphlet over there. And the goal is really to bring this education into the healthcare professionals taking care of patients with end-stage renal disease, so that conversation is started early on in the process. The dialysis centers only addresses those that are on dialysis, but those patients who are preemptive in the doctor's office who are in stage 3 and 4 needs to have this conversation also early on. So Cornell and Johns Hopkins also look at understanding barriers within the ethnic minorities in terms of what are the obstacles to living donation. And there are various levels of understanding of these obstacles, and so when we look at donor identification, I think when we look at the concerns, there's that medical mistrust. There are many patients who just don't want to have that conversation in terms of even discussing living donation. There's that reluctance. Oftentimes there's not a lot of knowledge and understanding, so I really think that's important to really have that communication. Suitability in terms of perceptions of suitability, often parents many recipients will say, okay, my brother can't donate, he uses drugs or he smokes marijuana. So there's this prejudgment in terms of avoiding the issue by coming up with a reason why they can't donate. And it really is about really having that discussion. Education within the educational setting in terms of, are they educated enough to understand the issues. And also in terms of the burden of chronic kidney disease, we have many more patients. The issue also relates to if you have a recipient with high blood pressure and diabetes, you may have some of these symptoms within the family members. So when you're selecting, with most patients would say, I don't have a relative who can be a donor. It's really getting to think outside the box, not necessarily a relative, but think about whether you're friends, or think about your circle of people that you interact with, your church members, maybe a bit getting that information out. But what we see more often is that reluctance to even have that discussion. So what about paired organ donation? This is an option that has been considered when we have those patients who may have a donor, but that donor is not compatible. You may be different blood types, A or B, or O and A, O and B. And so the issue becomes, yes, they want to donate. And so you then have the possibility of entering a paired donor swap. And so you can have your traditional two-pair exchange, where you have two pairs that are donated across from each other, provided you like each other. No, I'm sorry about that. Or you can do a three-pair exchange, where you then bring more into the equation, and you can create a chain if you're a part of a paired donor network, where they collect information from many different centers, and the computer decides what's the best match. And here's where, if you have that altruistic donor, that person who walks up the Christiana Care lobby and now wants to be a donor, we could be selfish and just select that patient for our own population of patients here at Christiana Care. Or we could be kind-hearted and say, well, let's put this donor into a paired donor network pool across the country and enter that person, who would then give a kidney to a hard-to-match recipient, which then crosses down the line. And so you get this domino effect where many patients will get transplanted based on the computer coming up with the best combination of matches that would give you the highest number of viable transplants. At the end, there's going to be someone whose the recipient got a transplant and now the donor is left. And so that person who is left, that kidney will go to the center from which the altruistic donor originated. So we may use that altruistic donor into the chain, but at the end of the chain, we will get a kidney back that we can then give to one of our own patients. So we end up saving the lives of probably 10 or 15 patients in that chain process. The optimization and simulation of a paired donor network is really looking at, if you have one to start with and many different pairs, how can you put them all into the pair donor combination, come up with the best situation? But you have to, some of it may be based on age, location of the donor, and travel. So certainly when we look at paired donor exchanges, you want to go from west to east because of the change in time. No one wants to have a donor arrive at 2 a.m. because a living donor kidney you can do at 2 a.m., but the option will be to use your donor the following morning to then use that kidney to get on a plane to get to the nearest center. So it's really about traveling across the country in terms of having the location, so you're not wasting time going back and forth. But it's an algorithm, and the computer puts all the information together and it works out. So let's talk about the problem we have in terms of deceased donation. So when we look at nationally, we take a survey, and over 85% of people in general support organ donation. However, we don't see the registration rates at the same. And so this is where we fall off. You may be interested in, you may think it's a good thing to do, but when you get down to actually having that on your driver's license or being proactive about it, that's where we're not seeing the numbers there. There are 47 support, but are not registered within the United States. So this is the issue that we need to deal with. So the majority of our donors are coming from deceased donors. We would like more, but it generally requires brain death. So many patients are reluctant because there's all these myths and misperceptions that I'm not even going to go into, where people say, I'm not going to sign my donor card. My grandmother went to the hospital, and she came for a broken toenail, and she turned out dead and became a donor. And so there's these mistrusts that you see. So it's still there. We still try to talk to people about there's need to be brain death, and understanding that it needs to occur, documented before someone can become a donor. You can also have cardiac standstill as an option, where we say this called donation after cardiac standstill. These patients can still become donors. They're taken to the operating room. They're taken off the ventilator because they cannot be declared brain dead. They're then allowed to die in the operating room with or without family. Once they're declared cardiac standstill by the medical physician, we quickly proceed to recover these organs and use them. We also have the use of hepatitis C. Kidneys from donors with hepatitis C to those who give to recipients who are hepatitis C positive, and the use of Cdc High-Risk we'll talk about. So our goal is to increase minority donation. We see, and this is some statistics from New York, they have minorities make up 65% of the New York transplant waiting list, but only 39% of organ donors. And so every year we have a National Minority Donor Awareness Week, the first week of August, in an effort to really educate our minority communities about the need for organ donation. MOTEP is National Minority Organ Tissue Transplant Educational Program that was started in 1991 by Clive Callender from Howard University to really address the issue of ethnic minority education in terms of organ and tissue transplantation, raising the need for more education and try to increase the number of minority patients and persons in the community signing organ donor cards. And he was able to make a dent in the DC area by really getting out there grassroots methods to increase organ donation and to reduce the disparities of end-stage renal disease in the minority population, bringing more awareness. At that time, there were longer wait times for minorities on the wait list, but this has been eliminated by the change in the kidney allocation system that now allows patients to gain time to the wait list when they come to be listed for transplant. That goes back to the initiation of the dialysis start date. So you have been on dialysis 5 years or afraid of kidney transplantation. Suddenly you come forward and want to be listed for a kidney transplant. You will gain those 5 years that you have been from the start date of your dialysis. In the prior system, your start date started when you showed up at the transplant center. So this was his focus, and one of the things was really looking at long-term survival in minorities and also increasing the donation rates and the wait list. So we'll talk a little bit about CDC high-risk donors that we begin to see a lot more of, and we're using these organs where in the past we did not. So Public Health Service increased risk refers to donors that could have the potential for increased risk of transmission of disease, particularly HIV, hepatitis B, and hepatitis C. And a potential donor is labeled as increased risk for a variety of reasons and the exposure that they carry at different transmission rates. Screening for deceased donors overall is routine. These are the things we screen for, but not necessarily the NAT testing except for hepatitis C and HIV. So PHS donors is by many factors. There's a small writing, but any definition is within the risk factors within the last 12 months in terms of those who have had sex with a person suspected of having HIV, hepatitis, men having sex with men, persons in exchange for money or drugs, birth up to a mother infected with HIV, persons injected intravenous drugs, and the list goes on. Also, those have been incarcerated, and high risk also includes your sexually transmitted diseases. Hemodilution is a big one in terms of patients having more than 10 units of blood at the time of before donation. So we do, for all the deceased donors, we do this nucleic acid testing because it reduces the risk of disease transmission. The highest risk that we're concerned about is usually HIV and hepatitis C. Not all donors get NAT testing because it's very expensive. We only do it in those cases where there is risk for potential infectious risk. The standard in terms of versus NAT testing, the one thing in terms of exposure of patients, let's say for instance, we're now having a rash of cocaine overdose, drug overdose patients. Someone passes out and dies in the Wawa's bathroom, comes over to Christiana and become a donor, needle in the arm or paraphernalia around them. Their donation can occur anywhere from the next day to 5 or 6 days, depending on progression of brain death. However, viremia may only appear in terms of at day 3 to 5. So there's this eclipse period where NAP testing may not be correct. Standard testing may not occur too much longer. In terms of standard testing, HIV is 19 days. With NAP testing, it's 5 days. Hepatitis B is 21 days with NAP testing, and hepatitis C is 4 days. So in terms of the window period, would be before 4 days in terms of explaining to patients the infectious risk with the new NAP testing. And so once that has occurred, certainly if the patient is at 1 or 2 days, you're still within that eclipse period, and there may be a higher rate of transmission. So all this information has to be given to the patient, and they have to be willing to and sign consent to receive one of these high-risk donor kidneys because of the risk of transmission. And so we talked about what we see most in our area is history of IV drug abuse and overdose, and sex with a person having history of IV drugs, incarceration, and men having sex with men. Those are probably the predominant ones that we see. Within our area, it's now up to about 35% of our donors fall into this category because of the epidemic. So 1 in 4 donors is considered an increased high-risk donor for infection. So in terms of these going back to older donors and use of donors with medical comorbidities, we used to use these nomenclature before, SCD, standard criteria, expanded criteria. Now we've moved on to allocation system where we're using an EPTS score for the candidate to estimate their survival, and also for the donor is a KDPI score, which predicts whether that kidney will be able to still be functioning in 3 to 5 years. And so this is how we rate our patients. The EPTS score in terms of the patient post-transplant has to do with the number of years they've been on dialysis, time on dialysis, any prior transplant, and candidate's age. The lower your EPTS score, the better you are. So if you're 20 years old, have no other factors, no diabetes, no previous transplant, you have a great score. But if you're 80 years, well, not 80, if you're 75 years old on our list with diabetes and had been on dialysis only a short time, your score is going to be very high, predicting that your chances for long-term survival may not be great. And so the KDBI score of the donor is given, and we know the score. So if we have a young donor who is, say, 20, the chances that kidney being alive in 8 years is great. But if you have a score of 95 for a kidney donor, then you see that the survival at 5 years is barely about 50%. And so patients are aware of this information at the time of organ offers. They may decline or choose to accept based on their age. The issue in using these older donors in terms of the organ procurement agency, they want every potential donor to have 5 organs being used. The transplant centers are saying we are under CMS regulation. If we use these older donor kidneys to our patients who are older, they may not survive. We may get cited at the center if our survival patients die more than expected. We get cited, and so we may go on probation. So there's all these issues that come into whether or not we can use these organs. In our mind, we're trying to think, is this patient good enough? And will this patient be alive in 3 years? Will this patient be alive in 5 years? So that we're not cited. So it leads to a higher discard rate because we're trying to predict whether or not this kidney is usable and can survive 3 years, which is the allotted time that CMS gives us for survival of patients. So I'm going to move fast as we are running out of time. Other pools for increasing organ donation is the xenotransplantation in terms of looking at genetic engineering and use of other organs. And in terms of using xenotransplantation across species, inducing tolerance, we really want to be able to, the pigs are used most often. There's a lot of work in terms of looking at transgender pigs, in terms of pigs that express those antigens that as humans we will react to. So the issue is how do we, using genetic engineering, remove those proteins from the pig cells to then allow humans to be able to accept these organs in pig organs down the line in terms of transplant. Some work has been done in terms of looking at not just using the pig kidney after you've genetically manipulated it, but also using the bone marrow from the pig that allows for early stem cells to then be implanted within the recipient along with the solid organ. So now you're using those original cells from your bone marrow of the pig along with the pig kidney. So you allow for genetic manipulation of your own bone marrow. So you become kind of chimeric in the sense that now your body has a cell line from this genetically engineered a pig line. And so your body doesn't necessarily, your own cell line does not recognize this organ as foreign because you also have those genetic markers from the pig. And so the goal is that in providing this method of tolerance, we can avoid immunosuppression long term. The issues with xenotransplantation is that pigs promote a terrible immune response. The genomes we have to worry about viruses that can affect humans. And we now have this gene editing technology, CRISPR, that allows for removal of certain portions of the pig genome, especially those that are the endogenous retroviruses within the pig genome. You can slice those out and replace portions of the pig genome with human genome to allow for that genetic manipulation down the line. In the past, this has taken years to be able to get to this point. Now it can be done much more quickly, and pigs can breed much faster. So this is I'm going to go into the CRISPR Cas9 technology, and the goal is really to have these genetically engineered pigs to grow to provide organs for humans. And I think the Chinese were able to have the birth of 37 such gene-edited pigs who now have human segments within their genome, and the thought that they are miniature pigs, so they only get to 150 pounds, which is ideal for using a kidney from that pig to a human. And so actually, I'm gonna move on to this one on the horizon. Last year, University of Alabama received a $19.5 million grant to look at engineering with xenotransplantation in the hope that they would be able to lead the country in producing genetically modified kidney transplantation from pigs by 2021. And if you think about it, that is not so far. Yeah, and before you know it, we'll be there. So there's a lot of work being done in terms of using pigs in these miniature ones, genetically engineered. There are those that have ongoing survival in terms of heart transplants and also kidney transplants in the lab, and we'll be able to see long-term survival of these organs, primate organs within humans. So there's much on the horizon to look forward to, and maybe we can have our miniature pig farm and have our pig organs and bacon too. Thank you so much. Questions?
Thank you for that wonderful presentation. Mary,
Certainly the question is the use of HIV positive organs, and which are being used only for HIV positive recipients. At this point, you have to be in a randomized center. Not everyone is qualified to use HIV because it really takes a multidisciplinary approach to using HIV positive organs. One, it's really within the hands of the infectious disease group, because we as physicians or surgeons, we're just putting the kidney in, but the management of those patients really falls on the medicines. And for HIV, and the monitoring by infectious disease, there's criteria for patients who may be listed for HIV and to get HIV positive organs. They still have to be virus negative. They have to have a CD4 count of a certain level. They cannot have, they can have a history of a CMV, but no history of aspergillosis. And so there are criteria that must be met. There, many patients fall off the list because while they're waiting for an organ, in the past, they developed an infection before they got transplanted. So the big issue is you need a big team, multi-center team, to really look and handle these patients in terms of the HIV drugs. One is building up the immune system to resist the virus, and transplant medication is pulling down the immune system so that you don't get rejection. So it requires a really fine balance to keep these patients virus-free. And also in terms of using positive donors, when I was in Pittsburgh, there were very few HIV positive patients who were willing to take an HIV positive donor. And getting that patients to agree to that, to then they're now virus negative, and then to get reinfected again potentially becomes a big issue.
It seems to me that one of the major issues in organ donation is also an economic issue, because donors, may not have the resources to stop working and to spend,
Right.
some days in the hospital to give their organs, as well as some of them may not be insured. So,
Right.
There
are many programs in terms. We have a policy in that a donor should be insured. If the recipient has Medicare, Medicare would cover all the hospitalization and transplant process for the donor. And that's in general. But what happens outside of that, beyond the 90 days at the hospital course, at a year? What happens if they develop other issues? What happens if you find that they have cancer during their workup and now they need to be treated? So that's the issue in terms of working up someone who may be uninsured. There are some funds available for living donors that helps them with the cost of being out of work. Some minor, maybe some travel, and cover some travel costs, but the bulk of their expenses will fall on them. And so patients have to be, most donors want to be able to say, but can I return to work in a month as opposed to 2 or 3 months? So laparoscopic surgery has made that, shortened the window in terms of patients returning to work, in terms of having that minimum incision. So those are things that we take into account in terms of donors. We may have planned that surgery at a time that the donor can take off. Maybe if they're have a few weeks off, then they may opt to take it in the summer as opposed to during the time that they cannot take off from work.
Is there any hope that there would be some funds, Medicare, to cover out of work?
That has been an ongoing issue in terms of with the living donor consensus with the ASTS and the UNOS, in terms of how do we provide better funding for living donors, perhaps even in terms of covering patients who are uninsured because they're willing to be a living donor if they don't have insurance. Yeah. And maybe the hospital can come up with a short policy of, how much does it cost to pay for insurance for 3 years for those potential donors who are willing to donate but don't have insurance.
Thank you for that great talk. In your one of your slides, you showed that there should be some screening for Epstein-Barr virus. Is that an absolute contraindication? It's pretty ubiquitous.
No.
To get it.
No, we do screen for Epstein-Barr virus with both the donor and the recipient. And so we prophylax in terms of if the donor is positive and the recipient has no antibodies, then they're covered with valganciclovir for 3 to 6 months to prevent recurrence of infection. And also within the younger population, EBV, 50% may be associated with post-transplant lymphoma. So that's one of the things we look for, but it's not contraindicated. Only with some medications. We have a newer drug called belatacept, which in its initial trials have found a higher incidence of PTLD in patients who were EBV negative. And so with that drug, to give to patients, you have to make sure that they have EBV, that they're EBV positive.
Cyclovir really is effective.
Just for herpes simplex. Yeah. Thank you so much. Oh, one more question.
I had. So again, about this economy. In the past, there was an issue with Medicare where Medicare would only cover, and I'm talking about the patients.
Yes.
The patients with kidney would cover the drugs and the.
It's still only being covered.
1 year? Or
it's 3 years.
And,
yeah.
And then what happened?
The goal for Medicare is that we will cover your medication, give you 3 years to find a job and get back to work and become normal. So the goal is that the emphasis is that now you're no longer disabled, you should be able to go out and find a job and have your own insurance. So what we see is that we see patients who are chronically on dialysis and disability for 10 years to get a transplant. Now we ask them to find a job, and they don't really want to that. And there are those patients who don't want to find a job, and they find it easier to just go back on dialysis because then they'll get covered. So it's a vicious cycle. Yes, I've been in transplant 30 years, and we've been fighting trying to get Medicare to cover the cost. If you look at the cost of dialysis for one person for the lifetime, it's like $1.2 billion. How can you not cover transplant? Thank you.